Hi, I'm Jennifer Prout, and I'm here to introduce Dr. Adam Lewin. Dr. Adam Lewin is a board certified clinical child and adolescent psychologist. He is also a professor at the University of South Florida, Merceni College of Medicine, and he serves as Division Chief of Pediatric Neuropsychiatry. He is the director of the USF Rothman Center and Tourette's Center of Excellence and interim Maurice and Thelma Rothman Chair of Developmental Pediatrics. Dr. Lewin specializes in obsessive compulsive disorder, anxiety, Tourette's and tic disorders, and misophonia. His work spans clinical care, research, and training with support from the CDC and the Misophonia Research Foundation. He is president elect of the Society for Clinical Child and Adolescent Psychology, a trustee of the American Board of Professional Psychology, and a fellow of the American Psychological Association. Today, he is presenting findings from his recent study comparing different treatments for youth with misophonia. Please welcome Dr. Lewin.
Thank you, and thanks so much for the kind introduction. I can shave off 3 slides and have even more time for questions. Well, welcome everyone. As introduced, Adam Lewin from the USF College of Medicine, and my appreciation to Dr. Rosenthal and team for the invitation today and for your attendance and interest in this topic. Today, I'll be sharing my findings from the first, and I think still the only published clinical trial for behavioral treatments for youth with misophonia. So this research was supported by the Misophonia Research Fund and the Ream Foundation. These are donations, not public dollars, that have really advanced the research and awareness of misophonia, and I'm truly grateful to be a recipient. As far as disclosures, other than the foundation grants, no disclosures today related to misophonia or any of the topics I'll be covering in today's talk. So as stated, our work is based at the USF Rothman Center for Neuropsychiatry in usually sunny St. Petersburg. I'm the director of the clinic. It's really a multidisciplinary team specializing in evidence-based treatment and training for kids with complex emotional and behavioral challenges. I got interested in misophonia when I was a fellow, really a resident at UCLA, and was immediately moved by the impact on patients, and especially parents, but families. The distress we saw in kids and the pain in parents when a child struggled to be in the presence of their parents for the basic daily activities and things that kind of bond us as humans, meals and time together like that. And subsequently followed the literature as the definition developed and these foundation funding mechanisms became available in groups like this. So very grateful to be a part of it. As I'm sure most of you know and have been hearing today, misophonia isn't about loudness and hearing acuity in most folks. It's about the emotional reactions to everyday sounds, chewing, breathing, tapping, that cause distress and impairment. The misophonia triggers of intense emotional responses like anger and anxiety. So our target is its emotional reactions to everyday sound. These sound triggers that cause intense emotional distress, rage, disgust, sometimes stress or fear, kids avoiding meals or needing to wear headphones constantly, at least they've gotten smaller, that lash out towards people they love, or the avoidance of family, the people and situations that are associated with the sounds. It can just be devastating to the kids and the teens and their families. So it's not just the sound, it's the emotional experience tied to sound. Sometimes the visual triggers too. And as a clinical psychologist, I don't treat the hearing. I'm not looking for the mechanical or structural basis for the sensory experience. I'm interested in the brain, mind you, but I'm working on the emotional skills, treating the emotions and helping build the skills to manage emotions via challenging our thinking and changing our behavior. So our goal isn't to eliminate the emotions. It's to help kids experience emotions with less distress and teach them adaptive coping strategies. We want kids to be able to experience emotions with less distress, less anxiety, and more control, or at least a sense of control over their feelings and behaviors. That we can shift the dialogue, the internal dialogue, from I can't handle this, I can't do this, to I can get through this despite some discomfort. That's a big shift. It's about building resilience and emotional flexibility and starting early. So we chose a transdiagnostic cognitive behavioral therapy because misophonia often occurs with a lot of other conditions, anxiety, depression, irritability, or at least symptoms of those conditions. We recognize that misophonia has lots of emotional and behavioral targets. It's not a single target. Transdiagnostic treatment in psychotherapy world means using tools that are not disorder specific. For example, a depression focused therapy or an anger focused therapy, but instead applying the tools that cut across symptoms. And that lens seemed really important for misophonia. It's a complex condition, and this flexible approach just made sense. Not just one thing, it's about the emotional reactivity, the autonomic or physiological arousal, the behavioral outbursts in some, or the family disruption in most. So instead of inventing a new therapy, we decided to use a transdiagnostic framework, one of those cross-cutting frameworks, and one that was commercially available, the Unified Protocols for Children and Adolescents. You might see it abbreviated somewhere in my slides, but I didn't fix it for UP. I tried to get the jargon out. These protocols really target core emotional processes like distress tolerance, anxiety sensitivity, flexibility. They're flexible, they're manualized, and they're widely available to trained clinical child psychologists. So the unified protocols, this transdiagnostic approach, targets emotional processes like distress intolerance, how we manage negative emotions, how we manage things that bother us in our daily lives, and anxiety sensitivity, how we deal with feeling uncomfortable, the stressors in our life. These psychological psychotherapy tools help kids respond or learn to respond differently to the uncomfortable emotions in their lives. And some of the tools that you may have heard or come across today or in experience with psychology, cognitive reappraisal, changing how we think about things, challenging our thinking, problem solving, exposure. I'll keep hitting back on that and how we use it, mindfulness, acceptance, and of course, relaxation. These tools help kids tolerate distress and reduce the avoidance. But back to the exposure piece, not by desensitizing them to sounds, but helping them face the sound triggers that are happening in their day to day life with new coping strategies, helping them manage the tough feelings instead of avoiding the distress, and learning where they can control. Sometimes it's at the level of feeling, sometimes it's challenging their thinking from I can't to I can, right? And sometimes it's what we can all do if we try, even though it sometimes is just really difficult and lousy, changing our actions and behaviors, even if we're not having a ton of success with changing our feelings. That's why we chose the Unified Protocols. It's a manual you can buy on Amazon right now or your marketplace of choice. Hopefully, any child psychologist trained in the last 20 years should be familiar with the basic skills in this manual. So we wanted to pick something that could be accessible if we found proof of concept here. So what did the study look like? We enrolled kids 8 to 17 with misophonia. It's a wide age range, but the protocols were built for a wide range of ages. Misophonia had to be the primary concern, but we didn't exclude folks that had other concerns. They had to be able to participate with a parent or legal guardian living with them because there's a strong family component to the therapy. And if they were on a psychiatric medication, the dose had to be stable. So we were looking at only one intervention change at a time. We ran a two-phase study. The first phase was an open trial. In an open trial, everyone knows what they're getting. There's no randomization. The purpose of the open trial, and here we only used the transdiagnostic treatment, was to test our approaches across the two sites. Make sure our trainings, our measurement, all of that was consistent and really get ready for the randomized phase where our raters were blinded to condition. They didn't know what therapy the kids were getting, and we could truly kind of conduct a pilot randomized trial. Of course, the pandemic hit right in the middle, but did most of this over a 3-year period. Kids were randomized in a 2-to-1 ratio to the transdiagnostic treatment, the unified protocols. And that's because we really wanted to look at the effect of this model as kind of the hypothesized model. We chose an active control condition. We didn't give kids a wait list. We didn't give them something we didn't think would be helpful. We chose relaxation for a few reasons. One, it's central to kind of is an evidence-based tool for treating anxiety and stress. There's good manuals out there. Most therapists should have that training. We also picked it as kind of an alternative, reading the literature, some of the concerns about exposure therapy, maybe a patient preference for relaxation-based skills. So we wanted to kind of pick something that seemed acceptable, had some evidence base, and gave folks a chance at good strategies, even if they were randomized to that condition. So there was no loser selected. So in terms of participants, we had 53 kids assessed, 43 were randomized. In that 2-to-1 ratio, 29 went into the transdiagnostic phase and 14 into the relaxation group. Only 5 dropped out, and only 2 from the cognitive behavioral therapy, the transdiagnostic therapy group. That's incredibly low. Done a few treatment trials in my short years, unfortunately not as short as they used to be. That's really an exceptional thing, and especially with the concern going into it that around exposure therapy with misophonia, practicing these calming skills in the presence of trigger sounds. We only had 2 dropouts out of the 29 randomized. And I think one was just a moving type exit. So that really suggests kids were able to do these skills, tolerate it, and complete treatment. So we were very pleased, even just without looking at results, that we didn't have attrition. A little bit about what the therapy looked like, although you don't have to be a therapist to buy the manual to kind of see what's in there deep, and I think there's like some free pages. The transdiagnostic treatment was delivered over 10 sessions, and a lot of the content included things like education. We added a little bit of misophonia specific education, relaxation, cognitive tools, exposure treatment, parent training, and a real focus on integrating the skills into real world settings where the problems were happening. Of course, celebration components of accomplishments and relapse prevention, how to keep this going as life moves on, and targeting key domains like distress tolerance, emotional awareness, and cognitive flexibility. But what was included? Well, kids are heterogeneous. Kids with misophonia are heterogeneous, and so are the tools here. But the boxes cover a lot of it. Fairly eclectic, but in a formulaic method, as per the protocol. The transdiagnostic treatment for misophonia really focused on kind of this emotional regulation, getting better at managing our strong negative feelings. Again, not on sensory desensitization. I say that a million times, I might get it right 2 or 3. This is not a therapy that we play the sounds, we have the kid in the presence of the sounds, and we expect them to get better, like we might with a fear. This is we use the exposure to practice the other skills, the emotional regulation skills, the cognitive skills. So it's a tool to help application. It's not what we perceive as the mechanism. So I want to make that distinction clear. I think it's gotten out there better than when we proposed this initially, but it's a fairly eclectic group of skills to practice coping. That targeting of distress tolerance, emotional awareness, cognitive flexibility, kids in general, but certainly kind of when we work with our kids with misophonia in the context of their triggers, flexibility is not one of the strengths. Helping them adjust to facing those triggers with confidence, using skills like acceptance strategies, reappraisal strategies, thought challenges, problem solving. How am I going to apply this here and there? And of course, kind of an overwhelming lens on improving emotional self-awareness and self-efficacy. Often kids with misophonia, they feel out of control with the sounds. And to some, it makes sense. They can't control what their siblings do. They can't control the volume in the school cafeteria. So instead, we're trying to help them refocus on what they can control. Feelings and behaviors. Might be hard, it might be difficult. We're not used to doing it. Even as adults, we're not used to doing it. But those are targets we actually can exert some control. And here we are to teach you the tools to do that. And with that, some reappraisal as we go to the ability to tolerate and manage those strong feelings. Breaking down the rigid thinking that I can't thinking to maybe I can, or this could be okay. And again, a very hard thing for adults, but for kids and teens, especially when they haven't had a long history of overcoming adversity, it can be really challenging. Another cliffhanger. The results were really promising. 54% of kids in the transdiagnostic treatment were considered treatment responders. 25% kids in the relaxation condition. As you can see from, I picked USF colors here. It's a meaningful difference between the two. Not as statistically significant. We didn't necessarily expect that given we used two active treatments and purposely put fewer in the relaxation condition. We used a very conservative definition of treatment response. As I've done more research, I always question when I read even a medical study, what's the response status? The definition here was very conservative. Essentially, if they were considered responders, they probably wouldn't get into the study in the first place. So a significant improvement both in terms of symptom reduction and improvement in functioning. So we were pleased that we saw this level, even though, of course, I'd love to see a 95% response rate. A couple other metrics of change. We looked at just reduction in misophonia severity. We saw a change over time in both groups, but a greater magnitude in the group receiving the unified protocols, the transdiagnostic. And if we flip it around here, higher is better. We see the improvement in functioning in this CGAS measure. So suggesting that kids got better over time, but as you can see from I'm colorblind, but I think the blue line, the transdiagnostic folks were doing better. This slide actually makes me quite excited, and usually as a researcher, I want to see group differences and talk to you about the group differences. Here, I was quite pleased not to see group differences. This is the treatment satisfaction, and a little worried that kids would find we like relaxation better. We come in, the sessions focus on down regulation, calming, some support skills. We go home. The one that really challenged kids to apply these tools in challenging environments and do the things that, man, we had tears sometimes in the intakes describing what the treatment would look like. We're going to practice these things. If anything, it's slightly higher. It's not statistically different. Parents and kids found both conditions highly favorable, and that made me happy. That the kind of myth that the kids couldn't tolerate this did not seem true. Teens actually rated it higher than that. We didn't put this on the graph than the younger kids. I can hypothesize on why that is, but that also made me happy to see adolescents finding a challenging treatment favorable. So this I think was really, besides the symptom reduction, a really good news that families going through this, despite the difficulty, found the benefit. Parents too, in feeling better and having better control over their distress. So as we wrap things up, unfortunately, life is really full of these invisible conditions that really change our experience with the world. And most people, at least most people old enough to have seen a chalkboard, can at least understand the intense emotional experience of sounds. But misophonia is so much more than that. And I think many people, they hear about it, but they just don't get it unless they're experiencing it themselves, or they have someone in their family, or maybe they're working with these families and just see it day in, day out, and the impact. The psychotherapy really focuses on helping us change how we interact with the world, how we perceive challenges, and helping kids activate resilience. Not targeting their sensory experience, not saying that there's anything broken within their sensory experience, but helping them manage their emotional experience, their self-efficacy, finding the strength to flourish in a world full of challenges and really full of things we just cannot control. So to wrap up, I want to emphasize that the study suggested that misophonia and patients with misophonia and their parents are highly amenable to behavioral treatments. The trial didn't rely on anything expensive. I'm grateful for the donations to operationalize it, but we didn't have to purchase any expensive equipment for the patients. They didn't need any specialized procedures. The doctors didn't need kind of robust new treatment development. It was all delivered in a manual that you can purchase. We did happen to have the as a co-investigator, co-PI, the person that developed it, but you can buy these manualized protocols. Any board certified child and adolescent psychologist trained in CBT, hopefully in the last 20 years or so, could do this. They might need to consult in terms of getting misophonia specific education consultation. But if they take the time to understand misophonia and its emotional components, the tools we use should be really fairly cross cutting. I think that's really empowering. Hopefully, what this means is we get the word out and test this further, extend the treatment. The families don't have to travel across country to find help. We can help them ask the right questions to find out if their therapist has these skills, and if not, how to help them find them with resources they already have, even though they might not have treated misophonia. So with the right tools and training, I think we can help kids build the skills to face the world full of sound triggers, hopefully with much better confidence and better control. So a huge thanks to both our teams at USF and of course partners at the University of Miami. Grateful to the collaborative effort across both sites and of course the donors, the foundation, and everyone who contributed. Appreciate the time being here today and happy to take any questions.
Okay, so we have to be quick with the questions. Thank you. First of all, thank you very much for that wonderful presentation.
My
I'm going to
pleasure.
try to combine some of these. So, one person is asking, had you combined both the CBT or Unified Protocol therapy with the relaxation therapy or protocol that you used, do you think the results would have been better?
Great question. So relaxation is a fair component for the unified protocols for the transdiagnostic. So you're absolutely thinking right. And clinically, yes. Clinically, we try to outside of a protocol, just kind of folks coming in, not in the context of this trial where we're trying to be adherent. We will absolutely apply some of the relaxation strategies, especially when the distress tolerance seems really high. Lots of times, the motivation to change varies. Sometimes we have kids and teens who are extremely motivated to get going, and sometimes the parents are recognizing, while the accommodations are helping us get through it, I want to kind of prepare my child to be better prepared for high school, for college, for dating, for driving, and so in those cases, the kind of willingness to kind of jump in maybe less. So sometimes they're kind of front loading, I think, with some of the more calming techniques forward, especially if in cases like that, or when there's less embracing of the problem. Many of our teens are the first to tell us this, for lack of a better word, sucks. I hate having this. And sometimes our folks, I'll say younger, but it's not always. It's not really a problem for me. It's a problem for everyone else. I'm paraphrasing, but there we might not kind of have a win with changing how they're thinking about things. Instead, all right, let's kind of work on those tools. We were more careful with the other condition. We're very careful in the other condition that didn't include the other components. So the simple answer is yes, we could include it. We should include it. In the trial, we were very careful not to include the other techniques in the relaxation condition to have a fair control.
Thank you. I just want to do a time check.
We're at
Quick
time.
We're at time, aren't we?
Yep.
Okay,
Mhm.
so Chris, I'll let you end this as I go into the
Okay.
break. Thank
Yeah.
you
Thank
very
you
much.
so much, Dr. Lewin. This has been very eye opening. Appreciate your expertise and your interest in researching misophonia. We're going to head over to the open discussion room now, and we're grateful for your being here and sharing your work with us.
Appreciate it. Thanks for having me.